Están ingresando todavía los asistentes, entonces damos unos minutos.
We are given a few extra minutes for people to come in.
Yo creo que ya estamos estables, Claudia, podemos empezar.
I think we can begin, Claudia.
Hola, muy buenos días y tardes para todos.
Hello, good morning, good afternoon
Este
for all of those who are connected to the webinar. And this is the vaccine-associated enhanced disease, case definition, immunology, and research and investigation. This is a strategy to strengthen the work on ESAVIs. We thank you for your presence here. We hope that you can connect without any problems, and we welcome the panelists, Dr. Salas and all our panelists, and I will give you some rules of the game for this webinar. I will share a slide with you so that we clearly understand the process followed for presentations and how you can access simultaneous interpretation, questions and answers, and also the recording of the webinar. Can you see my presentation?
Sí.
Yes. So very briefly, this virtual seminar has simultaneous interpretation. Please use the global icon. It's on the lower part of your screen, or the Zoom screen, to select your language of preference. We have English, Spanish, and Portuguese. Also, you can use the chat icon to communicate any technical or audio issue that you may have. And for questions, we will be using the Q&A icon, but many of the questions have already been received through a form that was sent together with the invitation for participation and pre-registration in this webinar. We will be working and answering those questions that have been selected, and there will be some time limitations to answer all of them, but for all interventions of attendees, it might not be possible to answer everything because of time constraints. This webinar will be presenting just the interventions of the panelists. So at the present time, I will show you the agenda. I would like to share my screen. This is the agenda for today's event. Dr. Daniel Salas will be presiding. He will have a few words to open this event. And then we have Dr. Flor Munoz and Dr. Stanley Perman as our guest panelists. And so without further ado, I would like to welcome you again. It is always a pleasure to welcome you. Dr. Salas, I will give much. It is a real pleasure to be here to pronounce these welcoming remarks to the webinar, aspects of a field that is not totally understood in all its scope. And we would like to start saying that PAHO appreciates the effort that the countries have made to strengthen vaccine safety, but this effort has to be maintained during COVID-19 and the vaccination against COVID-19. We had the urgent need to have tracking and follow-up of adverse events. But then the event is pretty much gone, and we know the COVID vaccines much better, and we have new vaccines. We have been introducing new vaccines that really leave a lot of questions unanswered regarding the adverse events. So there's a specific event, which is the vaccine-associated enhanced disease, vaccine-associated enhanced disease in English, and they are of special interest, and they require special care of the surveillance systems, and that was essential during COVID-19. But this vaccine-associated enhanced disease shows a possibility to have many unknown areas in vaccines such as the ones against measles or the RSV or dengue vaccines. There are phenomena that we do not really know how frequent will this phenomenon be present, what will be the form of presentation. And so with the new vaccines, we urgently need to study the occurrence of these events and to make sure that we have the cost analysis so that we can give the confidence to the population when we understand these phenomena much better. So from the operational standpoint, we should be able to transmit confidence and tell the people this is a possibility and the likelihood of having this event, and this is the way we respond. Always trying to establish a balance between benefits and risk. It's not recommendable only to show the risk of a vaccine, but we have to have a balance between risk and benefits. And also, Brighton collaboration was great with the definition of the vaccine-associated enhanced disease. And this definition has spread, and for that reason, we have this webinar. This afternoon, we have Dr. Flor Munoz from Baylor College and Dr. Stanley Perman from the University of Iowa. They are experts in the Brighton communication, and we are very grateful for their acceptance of our invitation because they will be teaching us about the clinical aspects, the immunology of these events, these vaccine-associated enhanced disease events. And they have actively participated in discussions with other experts in this area, and they will enrich our knowledge with their perspectives on this important topic. So we hope that many doubts will be clear as we know more about this so that we can formulate new strategies, especially since we have so many gaps in this knowledge. We always require the commitment, especially in the ESAVI programs, to make sure that we generate evidence so that we have better information and we can broadcast this information and share it at this time. Thank you. Thank you so much, Dr. Salas. Before introducing Dr. Flor Munoz, I would like to share the agenda that we will be developing today. After Dr. Salas's introductory remarks, we will have the presentation of our guest panelists, Dr. Flor Munoz, then Dr. Stanley Perman, and then we will have a question and answer or discussion and questions and answers headed or moderated by Dr. Felipe Molina. And finally, we will have the closing of the meeting by Dr. Álvaro Wittenberry. I will read a very small summary of Dr. Munoz's CV. She is an associate professor of pediatrics, and she works in molecular biology in Baylor College, and she is a consultant for infectious diseases in a Houston hospital. She has centered her investigation in the evaluation of pregnant women, children, and immunodepressive persons, and also in immunology and the treatment of infectious diseases in these populations. Dr. Munoz has been a researcher and consultant to the industries, the CDC, the Coalition for the Preparation for Epidemics, working with specific populations as part of the Brighton collaboration, and also in different WHO programs. And then also working on maternal health. This is a very brief summary. Dr. Munoz, you have the floor. Thank you so much. I appreciate it. Thank you for your kind invitation. Thank you, Dr. Molina, Dr. Salas. It is a pleasure to be here with you. I will begin my presentation by sharing this with you. And if you can tell me if you can see this well, thank you. First of all, thank you so much for the opportunity. I only speak English. I only speak Spanish, but my slides are in English. And if you don't have any trouble, I will speak in English so that Dr. Perman can have the opportunity of listening to this discussion. Dr. Perman and I were part of the Brighton group that worked on the case definition of this vaccine-associated enhanced disease. And then it really was a very interesting process, and I would like to share this with you. So now I will focus on how we developed the case definition, the Brighton case definition of the vaccine-associated enhanced disease, and to reach the consensus that has been published.
Dr. Perlman, so that we could also have a good discussion on this. These are my disclosures and some of the work that I do. Again, it's been mentioned already. So what I wanted to share with you is what Brighton is. Just maybe tell you very briefly. Brighton collaboration was founded in the early 2000s. This is a group of academic and also people in different organizations making decisions on vaccine safety that realized early on that it was very important, of course, to have vaccine safety information, but that there was really a lack of harmonization or consistent assessment of safety of vaccines. And because safety is very difficult to measure, sometimes we know that things are safe because there's no cases of an event, unless you actually are looking for them. There was an important need of having standard case definitions to be able to achieve consistency in the assessment and monitoring of safety of vaccines throughout their life cycle. So from the very early development phases in research and also in the post-authorization period. So this was the original goal, is to really have a scientific approach to the assessment of safety of vaccines. The Brighton collaboration has a very specific process by which they look at developing these case definitions. So it is a voluntary work that involves people with different expertise, people that have, depending on the topic of the adverse event that is being evaluated or that is being developed for a case definition. There will be, as you can see, a call for volunteers where you will have working groups that are going to be defined based on the topic with experts in the field, but also experts in public health, in vaccinology, in vaccine safety, in implementation aspects, regulatory aspects, and so on, so that there is a representation of expertise, but also geographic representation, global representation. We want individuals from all parts of the world to be part of this. And basically, we start by identifying what are existing definitions of a particular event. For example, fever is a very common one, and realizing that what one understands as fever could be very different for another person, particularly because of how it's measured and what the cutoff should be to consider it fever, in which populations, and so on. That's just a very brief example. But as you can see, it becomes an iterative process by which we start looking at existing definitions, references, what else has been done, how do you measure, and this group is going to develop then a case definition to try to harmonize that assessment and be able to have a guide for others to do the same thing. So Brighton has developed in the last 20 years more than 45 case definitions of adverse events for after immunization in different populations, and that includes special projects like the Gaia, which was focused on maternal vaccines, and then the SPEAK, which is a safety platform for emergency assessment of vaccine safety, that is under which the VAED, or vaccine-associated enhanced disease one, was created. The format is as you see here, in addition to having a definition of what an event is, we have levels of certainty, so that we have levels 1, 2, and 3, and they're equivalent to basically a definite, probable, or possible case. And this is really to try to see how accurate the diagnosis is when you have a particular case. And certainly for a definite case, which would be the gold standard, you would have the need to have resources, to have good diagnostics available, but it doesn't mean that you could not categorize a case into the Brighton case definition if you don't have all these resources, because you have a second or third level. It doesn't mean it's less important. It just means that the certainty, if you have a level 2 or a level 3, is a little bit lower, because you might be using less sophisticated diagnostic tools, or mainly just clinical assessment as opposed to laboratory confirmation. So that is just the concept in general, as you will see with the case definition. And the goal, again, is to increase accuracy of the diagnosis, precision, and also comparability among studies. So this is the document that I'll be describing to you. The vaccine-associated enhanced disease case definition and guidance for data collection, analysis, and presentation of a safety immunization data was actually published in early 2021, February 2021. So this was just literally a couple of months after, in the United States, at least in some countries, in December 2020, we had COVID vaccines. It was an initiative that started because COVID vaccines were being developed. And at that point, again, CEPI and SPEAK initiated a process by which in March of 2020, just as the epidemic had started and vaccines were being developed, there was already a need to address the concern, theoretical concern, as we have seen with other pathogens, that if you started to give vaccine to the population, there could be the possibility of a vaccine-associated enhanced disease. So as you can see, these are experts from the world. Again, Dr. Perlman is here. Thank you for that, because he's the real expert in coronaviruses and in this type of topic from the basic science standpoint. And you know, we met, as you can see, very regularly. In addition to that, there was a webinar. There was a very large global meeting that took place to try to address this. And I can tell you that that was very early in March also of 2020. The decision was made with very little data that the theoretical concern of vaccine-associated enhanced disease with a COVID vaccine was not going to be sufficient. The concern was not going to be sufficient to halt or to impede any development of the vaccines, but that there had to be some kind of guidance to be able to find cases and determine if this was going to happen. So that is the origin of this case definition. Now, the concept of a vaccine-associated enhanced disease is here. And so what it means is that there is a different presentation of a disease or an infection in people who are exposed to a wild-type pathogen after they have been vaccinated with a vaccine that is supposed to protect them against that pathogen, okay? So this implies right off the bat, as you can see, that you would have to have a vaccination for one, and that you would have to have an exposure to the pathogen, and that indeed the third thing is that you already have a good idea of what the clinical presentation of the disease is, and that is different. It's different or worse, okay? So these are some examples, and Dr. Salas has mentioned some of it already. Atypical measles was something that was described in the 1960s after utilizing a formalin inactivated measles vaccine in children. And what was noted is that children would develop, in addition to the typical measles rash, even after vaccination when they were exposed, they also had more severe cases of pneumonia, for example. So that was one case. The other has been enhanced respiratory syncytial virus disease, or RSV, that also happened after vaccination in some children, and I'll tell you a little bit more about that. And when you have, as you saw with measles or with RSV, disease that is mostly involving the respiratory tract, people have used the term vaccine-associated enhanced respiratory disease. But let me just tell you briefly, what the experience was with RSV, because it was also a formalin inactivated vaccine that was used in the United States. It was a particular lot utilized in the United States. There was a similar vaccine that was being used in Europe, and they did not see enhanced disease in that case. So this was in the mid-60s, and this formalin inactivated vaccine had been evaluated in at least these 4 clinical trials that are listed here where there was disease that was enhanced. That vaccine was given in younger children, usually in the first 6 months of life. And what you see in these 4 studies is that in the vaccinated group compared to the control group, there were more cases of pneumonia, quite significant in the top, 69% versus 9%, or more cases of a surrogate of the severe disease, hospitalization after having RSV infection. And that was, again, very significant in these cases. So 52 versus 2.5%, for example. And in 2 cases in the study of Kim and others, you see that 2 babies that were aged 14 and 16 months of age when they got RSV actually died from this enhanced disease after they had been vaccinated with this formalin inactivated vaccine earlier at 2 and 5 months of age, respectively. So this is what it's meant. You see, we already have an idea of what the natural course should be, but this is much worse. Or you have, as you see clearly here, a control group where you see the difference in the severity of the disease. Why this happens, this is probably one of the main topics of discussion.
Por que acontece, e esse é dos temas principais de discussão para o RSV, ou vírus sincicial, uma observação que foi feita ao tentar identificar o motivo é que a falta de anticorpo neutralizante funcional. Comparamos aqui com a infecção natural e vacinação, e aí embaixo vemos os anticorpos medidos por ELISA, um aumento nos títulos. Lamentavelmente, para os anticorpos neutralizantes ou de inibição de fusão, a vacina não resolveu em ter anticorpos adequados. Com RSV, a meta dos anticorpos não era a fase antifusão da proteína F ou de inibição da fusão. O que acontece é que há mais suscetibilidade à doença porque há anticorpos que não são funcionais e isto cria um complexo imune no qual temos mais dano ao tecido quando há uma infecção ativa. Eu vou continuar com a definição de caso. Aqui,
I'm sorry. go back. What you see with vaccine-associated enhanced disease is that you have, again, this primed individuals, so primed by the vaccination, that have non-protective immune responses against those viruses. And that this is what then results in the more severe disease. Usually, because you have, targeted immune responses, when you have vaccine-associated enhanced disease for a particular pathogen, the manifestations are going to be seen, the symptoms are going to be seen in the target organ of the infection to begin with. So if it's a respiratory virus, it will be the lungs. If it's a, CNS, it could be the brain, for example. And so, as you can see here, as I mentioned at the beginning, in order to know whether you have vaccine-associated enhanced disease, you actually need to understand already the basic clinical presentation of the disease and what its natural course is. And as you can imagine, for COVID-19, that was very difficult at the beginning because we just did not know. And we also know, so this is one process, what I just described for measles and for RSV. It's different actually from what you see in dengue. In dengue, it's not vaccine associated. It's independent from vaccine priming. This is something where you have sequential infections of a pathogen and you have some protection, but maybe not sufficient cross protection. And we've seen this as ADE, which is more antibody dependent enhanced disease in dengue and also in pandemic.
No dengue é independente do anticorpo.
Developing this.
Excuse me, Dr.
Yes, sir.
Munoz.
Yeah.
Sorry, we are having a problem with the interpretation. Sorry, I'm
Oh.
sorry about that.
Okay.
Estamos escuchando la interpretación de portugués en el canal de inglés.
Oh,
Le agradezco a la intérprete usar el canal correcto, por favor. ¿Podemos probar portugués? Ok, perfecto. Ya, puede continuar, doctor. Disculpe.
gracias. Okay. So I just wanted to bring you back to the SARS-CoV-2 epidemic and then again, the rationale for this. So remember that before SARS-CoV-2 in 2019 to 2020, we had MERS in 2012 and SARS in 2002. And we knew that these were related viruses that had resulted in severe disease with potentially high mortality, depending on the population. And so again, there was a theoretical concern that vaccinating against SARS-CoV-2 would have a risk for enhanced disease because like we said, with other respiratory viruses, we had seen this. And then again, in some animal models, you could see some highly pathogenic coronaviruses cause severe disease. But I have to say, and make sure that it's clear, that vaccine-associated enhanced disease had not been seen after giving the SARS or the MERS vaccines to humans. But of course, the vaccination was not as widespread as with COVID-19. And as I mentioned before, at the time of the development of this case definition, the pathogenesis, how the host immune responses and immunity to SARS-CoV-2 occurred were still not fully understood. So we also knew, and we were starting to understand, that there's a big spectrum of disease, from very mild illness to very severe SARS-CoV-2. And there could also be some post-infectious events, just like MIS-C and myocarditis and others. So this really complicates things because, again, the basis is here understanding your main clinical presentation. In addition to that, please keep in mind that as we talk about vaccine-enhanced disease in general, there is not a uniformly accepted definition, including clinical, laboratory, or histopathologic definition. So I'm already going to maybe disappoint some of you because there is not a single test that you can do and say, this is vaccine-associated enhanced disease. You really have to look at a congruence, and a compilation of events and pieces that need to fit in to be able to identify a potential case of vaccine-associated enhanced disease. As part of the definition, you see that we looked at the terminology that is used. So we call it VAED, vaccine associated. There's also VMED, vaccine mediated enhanced disease. We also have seen a respiratory enhanced disease or vaccine induced enhancement of infection, and then immune enhancement, disease enhancement, or antibody dependent enhancement. So you see that different terminologies that are being used. But I think that the main concern and the reason why we created this case definition is because these terms actually reflect potentially different mechanisms mechanisms for disease enhancement. And so they're not exactly the same. And when we use terminology that is not consistent, again, we can't compare signals, and we can't compare studies when these cases are being evaluated. So again, I think that here, another decision that was made by the working group for this case definition is that it was important to focus on the most severe disease within the spectrum of disease of COVID-19, because it's more likely in a general setting when you're introducing a new vaccine that you will be able to capture and identify more severe cases, say, that require hospital attention or that result in mortality, than milder cases. And the other important point to make, which I know it has come up in the questions, is that, maybe you have it's very difficult to determine vaccine-associated enhanced disease in one individual. You actually need to have more population-based data, but at the same time have individual assessments. But you cannot really make an association or assess causality in just one single case. So this is an important challenge for the definition. So the definition is really focusing at identifying possible and probable cases of vaccine-associated enhanced disease. And these are based on clinical presentation, again, the frequency of the occurrence of this event in the population, and also suggested clinical and laboratory findings. Note that what we don't have here is a level 1 of certainty. So we do not have the ability, with the current status of knowledge, and I think this is still true, to say definitively, that a case is vaccine-associated enhanced disease. And that is something that could evolve over time. So we talked about both clinical trials and safety surveillance post-authorization. And as I mentioned, in the sense that we don't have a specific test or a specific laboratory finding, a biomarker or histopathologic finding that is typical of vaccine-associated enhanced disease, the definition is not going to be prescriptive, and it's going to leave a lot of room for it to be adapted to the pathogens and to what is needed in the population-based surveillance. So again, the evaluation is going to be pathogen and vaccine specific. And this is something to keep in mind, that we also recommend consultation with experts when necessary. And so this can be used, the definition is to be used not just for COVID, but for other pathogens. I'll go through some of the levels of certainty and try to give you the background on this. So again, we, as a working group, and again, a lot of experts that had done work on this for many, many years, consider that it's not possible to ascertain with level 1 with the current status of knowledge, okay, and not understanding all the mechanisms very clearly. Level 2, I summarize here. So this will be a probable case. So what this is doing here is trying to give you even 2 levels of certainty within level 2. So probable, but more likely to be a case of vaccine-associated enhanced disease, it's a 2A. When you have someone who has never had an infection, but who gets vaccinated and then develops a disease that is laboratory confirmed with the pathogen that the vaccine was supposed to protect them, that has clinical findings that involves either the target organ or more than one organ, but that you have disease severity that is not consistent with the expected disease that the pathogen causes, right? With this, we utilize severity illness scores, as you can see. And you see the combination here is and not only one case, but you would have also increased frequency of a similar outcome, either severe disease, hospitalization, or death, in a group of people who are in the same situation after vaccination. And in addition to that, for this level of certainty, you will also have some evidence of immunopathology, either in the organs or systemically. And you see here, these are some of the findings that have been identified as associated with enhanced disease, depending on different mechanisms. It doesn't have to have all of these, but any of these could be present, such as eosinophils in the tissue, elevated cytokines that are of the Th2 pro-inflammatory type, CD4 cell deposition, which again, it's about immune complex activation, which is what has been proposed in the past. The C1Q, which is complement assessments, also with complement deposition, or low C3 levels. And then finally, you also need to have a certainty that there's no alternative etiology of the severe disease. So you see, again, the key here for the highest level of certainty, which is a 2A, is that this person is having this response after vaccination, but also after being exposed to the pathogen for the first time after vaccination. Level 2B is going to be someone in whom you don't know if they were seronegative before, or you don't have a history of infection, but you don't have the serostatus. Level 3 of certainty is a little bit simpler. So in this case, the ascertainment is also based on having a known infection, 3A and 3B, 2 levels of certainty. The difference here is basically that you don't have the lab. You don't have the laboratory findings or histopathology findings. You're just basing the decision on clinical and epidemiological criteria. So this is what I was telling you. You can do that, but you don't necessarily, you don't have the same level of certainty as when you do the laboratory evaluation, but you can still have suspicion for a vaccine-associated enhanced disease case. And levels 3A and B are the same in terms of A is for people who are seronegative before they were vaccinated, and B is for those with no prior history or unknown status. And you can see here, you basically do need to have the confirmation of the disease from the pathogen that the vaccine is supposed to protect, and then the clinical findings, severity of disease, and increased frequency of these outcomes in a group of individuals who are vaccinated. All right, so I'm just going to give you some key considerations. The importance of having seronegative status prior to vaccination is key. Most of the times you can't do that unless you have laboratory testing in a clinical trial. So that's important to keep in mind when doing the investigation. Vaccine failure has also been addressed. So what is vaccine failure versus, a breakthrough infection? So breakthrough cases are cases of a disease where you have been vaccinated and basically you still got infected. But it's very different when you have a vaccine failure, which is you did not respond to the vaccine. You have no immune response, and therefore you still got the disease, versus a potential case of breakthrough with vaccine-enhanced disease where you actually do have an immune response, and on top of that, you get infected, and then you have additional symptoms. So I hope that's clear, because I know that was one of the questions as well. And so again, I mentioned here that because you need to base it on the knowledge of what the disease looks like originally, you need to know the difference when it is actually worse or unusual. And you need to know what characteristics to look for, and how to assess this is based on usually severity illness scores, toxicity tables, or collection of the typical severe adverse events that we utilize. You see that again, if you have a population-based information, it's better. So it might show vaccine-enhanced disease as a difference in clinical trials, like in the case of RSV, where you have vaccine versus control, or compared to background rates in the population, where you have more cases than what you would be expected in the population. And then I'll show you some of the tables where you have either clinical characteristics or laboratory evaluation to be able to assess this. And looking at a committee that is going to help you adjudicate, or expert consultation is going to be important. So I won't spend too much time on these because they are in the document, but the document is going to show you specific factors to consider, and these reiterate some of the findings of developing a clinical case profile so that you understand the difference between the normal course of the illness versus something that is enhanced, utilizing grading or severity scales that are consistent in the evaluation of all the cases so that you have harmonized data, and then being able to follow them over time. This is assessment in terms of clinical and laboratory diagnostic parameters. Here you see, for example, by organ system, what we did is divided clinical findings, such as, for example, respiratory tract, having a cough or having respiratory failure, and matching parameters such as measuring oxygenation or A gradient. Same thing for the heart. You see manifestations such as hypotension or myocarditis, but then making sure you measure as well EKGs or troponins, for example. So this was a lot of work, as you can see, where you can already start thinking about how to implement the case definition when you are assessing cases. We're giving you already some tools there, both from clinical and laboratory findings that would match. And then the other pieces that are very critical are making the diagnosis of the infection, so identifying the virus that is causing the infection, and make sure that that is either a wild type virus or that it is the vaccine virus is going to be important. So characterizing that virus whenever feasible is very important, and quantifying it as well, because that's also a concern. The amount of virus that is present could be associated with enhanced disease. Assessing the immune responses, number 2. So this is immune responses after vaccination. So how do you differentiate, vaccine failure versus, enhanced disease? It's because you see that there is an immune response after the vaccination, and then you look at the immune responses with the infection, and you see that there's a discrepancy there with the neutralizing activity, for example. So that is important, not just total antibody, but the functional activity of the antibodies, neutralizing affinity, and other assays. And then the last 2 are going to be inflammatory responses, which include basic cell counts, but also markers, cytokines, and if possible, histopathology. So, I think I'm showing you all this because the key is that it's going to be very hard to do this retrospectively, but unless you have a protocol that is going to look for it. And then this table is going to give you some of the suggested laboratory evaluations, and what it means. So for example, when you are concerned about you don't have a good neutralizing activity, you could have findings of low immunoglobulin titers, low neutralizing titers, for example, low affinity, and so on. So this is trying to give you the interpretation of evidence of either poor immune response or an exaggerated inflammatory response with those specific cytokines that you can see listed there, or by histopathology. And then this table here is going to also give you some of the factors to consider. I'm just going to show you what's on the left side for the sake of time. Again, we mentioned the importance of background rates. So having a good sense of the population-based occurrence of a certain event, it being pneumonia or hospitalization for sepsis or mortality associated with the disease itself. But it's important to make sure, that the data, the background rates are very specific or pertinent to the study population or to the population that is being assessed, and also contemporary as possible, unless you, again, have a control group. Age and gender, there could be differences by age group. COVID, we had a lot more severity with extremes of age, and that is natural course of the disease. It's not enhanced disease. Gender, there could be differences as well. The time of onset, I think, is interesting because, this was a big discussion within the working group, in the sense that, we usually associate vaccine adverse events to a temporality, something that happens shortly after the vaccine. But in this case, the mechanisms are different. And so depending on that, you can have clinical manifestations that could be vaccine-associated enhanced disease, either shortly after the vaccination, if you have, a failed response or inadequate response, or later, if you have, as we saw in the cases of RSV, poor immunity and then exposure occurs later. So it's a little bit different depending on the case. And for that reason, the working group suggested that if you are working on looking at these types of cases, you do need to ensure follow-up of the patients, especially prolonged follow-up over time after the vaccination of at least 1 year is what we suggested. The clinical course and progression of symptoms also needs to be addressed. And I just wanted to show you this here because this is matching very much what we do in terms of assessment of serious adverse events, or SAEs, right? So death, hospitalization, worsening of an existing disease, prolonged course or additional complications, long-term events. That is something that could be consistent with vaccine-associated enhanced disease, and we capture it in most studies. And then finally, the other factors, obviously need to make sure that you have ruled out other infections, other drugs, other toxicities, comorbidities, anything else that could be a contributing factor, because that is part of the definition. influence of treatment. So that is not likely to be a factor, to be honest with you. So response to treatment is not something to consider to make a diagnosis of vaccine-associated enhanced disease. But the type of vaccine could be. So I have there, different platforms, different adjuvants. It is important to document that. And we mentioned already vaccine enhancement versus vaccine failures. So that is key. So I just want to finish by saying we provide in the document some examples of severity assessment tools. This is the SOFA score. There's actually one for pediatrics as well. And you see how basically if you use a tool like this consistently, you can actually compare not just progression in the same individual, but also severity of disease consistently among the population. And the last comment I want to make, because maybe some of you might be wondering, so what do we do with this definition? So there is a protocol that is being implemented by the Global Vaccine Data Network. You see there, it was developed last year to try to identify vaccine-mediated or vaccine-associated enhanced disease in patients that had received COVID vaccine globally. So these are sites that are representing different areas of the world. And you see that they use the case definition and they utilize these proxies based on the case definition, like hospitalization, all-cause mortality because of COVID, mortality from COVID, ICU admission, and again, sequential assessment of the SOFA score, which is what I showed you, or other parameters to see if indeed they could compare vaccinated versus unvaccinated and see if there was any association of the COVID vaccine with VMED. So far, I don't think there has been any, to be honest with you, but just to show you that these protocols could be potentially implemented. And I will stop there, and thank you again for the opportunity today.
Claudia, adelante.
Claudia, go ahead. I'm here, but I do not have the screen. To continue, I thank you, Dr. Munoz, for your presentation, and let me remind you that the questions can be presented by using the icon at the bottom where it says questions and answers. And to continue with the agenda and the topic to be discussed today, we're going to continue with Dr. Stanley Bergman, who will be referring to the immunology, the physiopathology, diagnostic, immunological diagnostic, and recommendations for investigation in terms of VAED. He is a distinguished researcher with the Iowa University. Dr. Beckman has a PhD in biophysics with the MIT in Cambridge, Massachusetts, and he also studied in the University of Miami. He also had a degree in pediatric diseases in Boston, Massachusetts Hospital. He is a member of the FDA, and also he is an advisor on COVID-19 and a member of the Committee on Immunization Practices. His current efforts on immunization focuses on coronavirus, including the demyelinization due to SARS, MERS, and COVID-19. His lab developed several animal models, which are quite useful and novel to study the pathogenesis and analyze viral vaccines and treatments. And his research focuses on the loss of senses, taste, and smell, and also any diseases related to COVID-2 and MERS. And Dr. Bergman, I hope I didn't make a mistake in reading your resume. I didn't make any mistakes when I read this, and thank you for being with us today.
So I want to thank the organizers for inviting me, and I'm sorry that my Spanish is really deteriorated since my years of being a medical student in the University of Miami. So it's very hard to follow Dr. Munoz's presentation. She is the expert in the field, and she's really covered a lot of the things that are really important for this topic. So as she mentioned, that a lot of this will be somewhat repetitious, but it'll be a slightly different take on some of the things. So I hope it won't be 100% overlapping. So to my mind, this disease, VAED, is easy to understand, but it's really hard to demonstrate in clinical settings. It requires atypical, modified, or more severe presentations, as was already mentioned. And I think that the key way that people actually come up with this is through epidemiological studies. As Dr. Munoz mentioned, it's very hard to detect in a single patient with a single set of events. And this is, in fact, something we deal with the COVID-19 vaccines, where patients come in with what they think are what may really be an effect of the vaccine, but it's very hard to distinguish one-off cases from widespread problems. And so early during the COVID-19 pandemic, the challenge was distinguishing VAED from disease breakthrough and vaccine failures, as was mentioned. In other settings, such as measles or RSV, the problem became apparent quickly because infections were widespread and problems were widespread. But there were effects of measles many, many years after vaccination. So it's hard to figure out what's going on. Often in experimental animal models are often very critical for understanding VAED, but also, as we learned with RSV, very, very hard to duplicate. So one of the things to think about with this kind of responses, so when one's exposed to a pathogen or to a lesser extent to a vaccine, what happens is that the host recognizes that there's a viral infection. And let me just get my pointer on here. The host recognizes, in this case, SARS-CoV-2, recognizes that there's an infection going on. And the first thing that happens is there's an innate immune response. And if one has pre-existing vaccination, then those adaptive immune parts of the response, the T cells and antibodies, are quickly activated by this innate immune response, and they clear the pathogen. And then what happens in the natural infection and also in the vaccinated individual where the process is working properly is the T cells particularly turn off this innate immune response. Because if the innate immune response continues unchecked, that's when one develops much of the severe disease that one sees in infections, particularly in early phases of the pandemic. One saw that in patients who were infected with SARS-CoV-2. And in turn, this innate immune response actually helps to activate dendritic cells and other parts of the immune system that lead to a good T cell and antibody response. These are accelerated in somebody who's been vaccinated. But just to re-emphasize this, one needs an innate immune response to activate the cells that lead to a good adaptive immune response. And the T cell response particularly is important for turning off the innate immune response. So the response has to be coordinated in order to have an effective response to a pathogen. So what happened with these other vaccines? This was already mentioned a bit, but with the RSV inactivated vaccine, it was initially protective, but ultimately turned out to not be protective, and there were 2 deaths from vaccination and challenge or infection. And the pathological findings included neutrophil and eosinophilic infiltration of the lungs, immune complex formation, or complement activation. One of the challenges here is that there were 2 deaths, so there's very little tissue diagnosis. So what we learned, a lot of it is from what we see in the blood. And in animal models for years, people have worked on trying to figure out how vaccine-mediated problems occurred, and it was partly because the T cell response was biased more towards allergic responses, Th2 responses. Non-neutralizing antibodies were induced, and there were immunopathological changes. In measles, it was really striking that there was a very atypical clinical presentation, as Dr. Munoz mentioned. The protection was also very short-lived. There's a rapid loss of neutralizing antibodies. and there was a Th2 cell response. Both of these vaccines, of course, put off vaccine development for either a short time in the case of measles or in a longer time in the case of RSV, because these vaccines had such problems. And so then the other kind of problems that one can have after vaccination is antibody enhancement. This is a macrophage infection, and this was again mentioned. Dengue virus is the classic example for doing this. And in this case, it's not due to an aberrant antibody or T cell response, but rather because the antibody that was induced enhances infections of macrophages. And this was shown in a coronavirus infection, feline coronavirus, which also had antibody-enhanced disease. This is a virus that normally causes mild to gastrointestinal disease in cats. In infected cats, the virus mutates spontaneously and then enables macrophage infection. This infection is uniformly fatal. It's called feline infectious peritonitis. But the good news is that there's actually drugs now that can treat this infection. They were developed before the pandemic, and they were also protease inhibitors, just like Paxlovid. And then the way this occurred in nature was vaccination with not nature, but vaccination with constructs containing the surface glycoprotein resulted in more rapid disease in vaccinated cats. There was more abundant macrophage infection. So this occurs normally, but it's normally not enhanced. So the cat would die anyway. But the presence of the vaccine or prior administration of the vaccine made disease worse and more rapid demise of the cats. Curiously, this enhancement is not observed in naturally infected cats. Oops, this should be cats, not mice. So unlike dengue, which naturally causes cases of ADE. So there was a concern during the pandemic, as was mentioned already also, that vaccination would result in enhanced disease. And this was based on several studies that showed that mouse vaccination with vectors expressing nucleocapsid protein or an activated SARS-CoV, this is the original virus, resulted in a non-neutralizing antibody response, possibly a Th2 response. And there were some pulmonary infiltrates with eosinophilic infection. There was also a study that showed that if one vaccinated macaques with either vaccinia virus expressing S protein or infused anti-spike protein antibodies and then infected the macaques with SARS-CoV-2, there was increased inflammatory infiltration into the lungs. And there was, in this particular study, they showed there was a change in macrophage phenotype from wound healing, or M2 macrophages, to pro-inflammatory macrophages, M1. And there was increased expression in IL-8 and CCL2. Both of these experiments, or both of these assays, for the most part, or these vaccination trials, even though they caused what one might consider immunopathological disease or vaccine-enhanced disease, caused almost no changes in clinical outcomes. So macaques were generally resistant to SARS-CoV-2 in terms of clinical disease, and by being vaccinated, even though the lungs looked worse, there was no real change in clinical outcomes. In terms of the mouse studies, in at least one study, there were no changes. I think in the other, there may have been worse outcomes. But the biggest changes were in the histological findings in these animals and the cytokine measurements. So this is one of the points that I'll emphasize again, that the one can have abnormalities here. In this case, it's the opposite of what would happen in patients, because in patients, you would find there'll be a clinical change that'll require investigation. Here, we can say there's histological changes, but no clinical manifestations. So in fact, finding these clinical findings may not be particularly critical for understanding human disease. So the way, as Dr. Munoz mentioned, the key thing is to figure out who to investigate and how to do that. And so I think that the critical thing is to figure out who could have be vaccine-enhanced disease. And this will be based on epidemiological studies, I think, to a large part. Certainly for measles and RSV, it was by seeing many patients who have these problems that people began to realize the vaccine was the cause of the problems. In other cases, in dengue, it's been known for years that this exposure to a second unrelated dengue strain will cause a disease that's worse than the initial infection with the first strain of the dengue virus for the most part. And as I mentioned already, in this macaque study, one sees an augmented cellular infiltration, but is this really a problem? And one thing that's notable is that when we do studies with mice with either SARS-CoV, MERS-CoV, or SARS-CoV-2, we find extensive peribronchial and perivascular infiltration, and this actually correlates with protection. So in mice that do poorly and lack these infiltrates, there's the presence of pulmonary edema, and this actually correlates with worse outcomes. So how do you actually determine if someone has VAED? Again, Dr. Munez did a wonderful job describing possibilities, but these are some simple tests that one can do. One can obtain blood samples, and of course, that's what one's going to obtain for most children or adults with what we suspect to be VAED. We can get CBCs looking for eosinophils. And if the suspicion of VAED is strong, then measuring neutralizing and non-neutralizing antibody titers. This can't be done in many places. This requires a level of laboratory expertise. Sometimes one can detect antigen antibody complexes, which can also be measured in vitro and also complement activation. Then I think the next level of testing is even more complicated. When one wants to measure T cell responses, this has to be done in specialized laboratories. And sometimes if one wants to look for specific pathogen responses, one needs to really have a set of possible peptides, because T cell recognition occurs via the specific HLA or MHC molecule expressed by an individual. This will differ from person to person, so it becomes more complicated, and one needs to use a broad panel of peptides. An appropriate response would be the production of interferon gamma, TNF, and IL-2. A non-protective response might result in Th2 cytokines. And then one can also measure levels of pro-inflammatory cytokines in the blood. But this has to be compared to people who are unaffected and people with severe disease, because this is really the the critical distinction. Is somebody have disease or vaccine breakthrough or vaccine failure, as was mentioned, or is this really a vaccine-enhanced disease? And then also one can measure antibody-mediated enhancement of macrophage infection, which has to be done with specialized expertise. So who should be investigated? As was mentioned already, and we must first, you have to investigate other causes of vaccine failure, or in addition to investigating VAED, as well as many of the other things that Dr. Munez mentioned. So there could be a poor innate immune response, leading to poor antibody and T cell responses. In severe disease, and this was noticeable in SARS-CoV-2 infections, lymphopenia may impact the generation of optimal T cell and antibody responses. That we also know that antibodies to interferon are found in many patients, and there are genetic defects in interferon expression or signaling. This could also lead to worse disease. So this could occur either in the presence or absence of vaccination. There could be excessive myeloid responses, which can lead to prolonged inflammation. This again would occur most likely in the presence of a suboptimal immune response. And there could be an increased number of immature pro-inflammatory neutrophils. There could be autoantibodies, which also inhibit the response to a vaccine and don't represent vaccine-enhanced disease. And then there's this specific kind of antibodies, afucosylated antibodies, that can cause increased disease severity. And then there were also unusual manifestations of severe disease, which may or may not occur in the presence of vaccination, but could be different from vaccine-enhanced disease, such as hypercoagulation and thrombosis and endothelialitis. These were seen earlier in the pandemic, and now with different variants circulating and the presence of antibodies and T cell responses in almost everyone because of vaccination or prior infection, we don't see this so much. And in severe COVID-19, we saw T cell responses that were sometimes allergic or antifungal, Th2 or Th3, and Th2 responses are also observed in VAED. So it's potentially confusing. So it seems that to me that once the host defect is not the cause of enhanced atypical, more severe disease, we could do the following might be reasonable to do. Of course, careful clinical monitoring, determine the vaccine history, what type of vaccine did the patient receive, how long ago was the last vaccination or natural infection. Vaccine waning could make VAED more likely, but also breakthrough more likely as some neutralizing antibodies decay, which we know occurs after all the vaccines, the SARS-CoV-2 vaccine. If a live attenuated vaccine is used, there's a case of reversion. This doesn't occur commonly, but could. And so obtaining and sequencing virus from patients with whom we think VAD is occurring is critical. And then, of course, reporting the cases to public health authorities is critical to help with the epidemiological studies. And then, as I mentioned already, some of these laboratory testing will help in trying to distinguish VAD from failure or breakthrough. And so what do we need? And so I think that the first line here is really the most important thing. If we could identify a biomarker to distinguish a dysfunctional immune response from vaccine failure or breakthrough, that would really be the best thing. Now, this kind of biomarker or other manifestation is, if we don't have it, I don't think there's even a hint right now of our having it in the near future. It may turn out to be a constellation of parameters that we can measure, but this is often not useful because the people who have VAED and severe disease may overlap. So it may be hard to do this, but at least if one had a constellation of markers that seem to distinguish VAED from other causes of increased disease, then this would be helpful. And one of the things is we need to understand the correlates of protection for the infection in question. If the correlate is mostly neutralizing antibodies, then one can study the antibody response and know that may lead to a more definitive answer. In other cases, T cells might be important. So this is all important in trying to figure out VAD. We have to do careful surveillance for breakthrough infections or VAD. And this is really important as well, which was mentioned already, I think. We have to standardize protocols, definitions, and make sure our data collected uniformly across patients in a given area. So the bottom line, and this will be my last slide, is the diagnosis of vaccine-associated enhanced disease is difficult, especially in the individual patient in the absence of epidemiological support, which is, I believe, that the way Dr. Munez started her presentation, and I will end mine. So with that, I will stop.
Doctor, mil gracias por su presentación. A la doctora Flor Muñoz también.
I
Muchísimas
thank you, Doctor, for your presentation. I also thank Dr. Muñoz. And now we are going to open up the session for questions and answers that will be moderated by Dr. Felipe Molina. I thank you, Claudia.
It has been very insightful presentations. Since this topic, it's not very easy to grasp at the beginning, and we have a very broad audience too. Many of us are not immunologists or are experts in very specifics that you have taught today. So I might ask you, or maybe I would like to propose to clarify some aspects that you have touched on your presentations. So the first one, it's and it's related to the questions I have sent you in advance. The first one is just to have a yes or no, and why is the reason for that. It's why is not possible to have an independent or case-by-case diagnosis of vaccine-associated enhanced disease. So why is it that we cannot do? Because that's one of the most frequent asked questions that we have had from countries and from people that are doing surveillance. It's how do I know if one case, one patient, severe disease is due to a vaccine-associated enhanced disease? So maybe if you can again come back to it and explain in more details, in a more flexible way. You can intervene, both of you, if you would like to. Why we cannot do a diagnosis case by case at this moment of vaccine-associated enhanced disease. So why is that we need epidemiological data added to the situation of the individual patient to diagnose or to suspect a vaccine-associated enhanced disease?
I could start from the clinical standpoint because, you know, I'm a clinician, I take care of patients, and I think the main reason is because the spectrum of the diseases that we're talking about is very wide, meaning that it's not uncommon that you could have a severe case just from a particular disease, right? So we're talking about COVID, you're talking about RSV, you're talking about pneumococcal infections. You could have severe cases. But you also have other factors to consider. So it's not just a severe case, it's also other contributing factors. So maybe it is a severe case because of the age of the person, or because of immunocompromise, or because of some other medications, or, you know, other factors that are there. So just one severe case is not going to alert you of vaccine-associated enhanced disease. And I think that the main challenge there is to be able to identify a pattern, right? So you could have isolated cases, maybe as what was happening with some of these events that occur with measles and with RSV, that you would really have to be alert of, again, something beyond just a severe case, and a pattern of cases where there is something in common, and that would be the vaccination. And then you would really need to, from an epidemiological standpoint, starting to look at that pattern and those numbers, the frequency of the particular syndrome that is usually quite characteristic. And this is without even going into the laboratory part. So it's very difficult. You know, it's like saying, for example, right now with RSV vaccine, right? Are you going to worry that every case of preterm birth is caused or associated with the vaccine? No, because there's a background already understood that there is a number of there are a number of pregnancies that are going to result in preterm birth. So it's the same thing. You're going to have severe disease. Is it just really something that you start seeing beyond and above what you expect? Then you start investigating. Hope that makes sense.
Thank you, Dr. Munoz. I don't know, Dr. Perlman, if you have any thoughts on that.
No, I agree completely with that. And I think you can think back even to the measles one, where we changed from having one kind of rash to a different disease. If one is the physician seeing that, or healthcare provider seeing that first case, one's going to look at that and say, well, this is odd, but you won't immediately jump to thinking that this is a vaccine cause. First, you'd have to diagnose the disease. You'd have to prove it was caused by measles at all, because it wouldn't look like measles necessarily. And then you'd want to find out if this was being found in other patients before one jumped to the conclusion that this was a vaccine-induced disease. So I think it's not trivial. As I mentioned, even with the side effects of the vaccine, with side effects are real, whether they're caused by the vaccine or something else, it's really hard to do without knowing that there's a basis for thinking that this is vaccine induced. So epidemiology, I think, is really critical.
Okay, very good. So what I could get from that, and as we have understood how to recommend countries to be prepared to monitor this, is first be prepared to identify patterns, clinical patterns that are not usual, as well as what we observe in the disease that we are trying to prevent with the vaccine. So try to observe vaccinated populations and to identify patterns in that population, clinical and epidemiological, right? So, and the second question, it would be related to in the Brighton collaboration definition, you say that one of the steps that you need to take on to assess the level of certainty is to diagnose the disease. So you need to first know if that patient had dengue or RSV, but we couldn't find a mention on a recommendation on the kind of test that you should do, meaning that I know it can be adapted to each disease, that depends on each disease, or is there any recommendation or any consideration in the definition of Brighton on the performance of the test? The example that we have is dengue. There are many ways to diagnose dengue, and countries or hospitals might have some available or other are not available. So is there any impact on the test to be used to diagnose the disease on the certainty level? Because it's not the same if we diagnose dengue by a rapid test, for example, as compared as to PCR, for example. So, and we didn't see that effect of the performance of the diagnostic test in the case definition, in the certainty level. So I don't know if you have had any discussions on that whenever you were discussing the definition.
Yeah, that's an actually important comment, because, indeed, there is no prescription of which test to use. But I think that if to ascertain, but for one point is for sure, you have to document that the person is infected with the pathogen that the vaccine was supposed to protect them. And clearly, there are different level categories of precision or, of sensitivity in of tests. So ideally, if you just want to translate into the levels of certainty, certainly you would want to know with the highest level of certainty the isolation of the pathogen or identification by PCR, for more modern technologies, that would be more definitive. I think it's, if you have something that is more sensitive and specific and also standardized and validated, that would be the ideal. And that if not, then anything under that might just give you, some assessment, but not definitive confirmation of a case, would fall into a lower level of certainty. But if you have diseases that you can confirm, for example, with acute and convalescent serology, that's appropriate as well, even if you didn't identify the pathogen. So I think this is more of on a case by case, really assessing how accurate your diagnostic tool is.
Okay, thank you very much for that.
I would just add to that what we learned from the pandemic is you just do what you can do. So if it's easier to do an antigenic test, it may not be as perfect, particularly if it's not really the best test. But if that's what you can do and you can't do a PCR test, then you do it to get information.
Okay, very good. Thank you very much. There's one big question related, and during COVID-19, we had a lot of that question related to vaccine failure and breakthrough infections. So we understand that breakthrough infections are those infections that comes after vaccination in a vaccinated patient. It's more a clinical observation or a patient observation, as we understand that. And the vaccine failure is more immunological term that can be observed. I mean, if we can say that if someone has an infection after one immunization, it can be a vaccine failure. But people can get infected with the pathogen after an immunization, because in the case of dengue, we have the example that there are other serotypes, but also due to a waning of the immunity. So from the immunological and the clinical standpoint, do you think, and how do you think it's easier, if you can come back to that, how we can differentiate vaccine failure from breakthrough infection? It is necessary to differentiate them, how they are related. So can you please explain more on that? Try to come back at that and clarify to our audience what's the difference, or if there is any difference, what's the relationship, and how they can see it from the clinical and immunological standpoint.
Yeah, I think you said it in your question, right? So I think that clinically, you can't say, right? So if you have an infection in a vaccinated person, there could be many reasons. All you know is that maybe you call it breakthrough because it was supposed to be protected, but no, rarely a vaccine is going to be 100% protective. Also, you have the issue of waning immunity. Also, you have the issue of multiple serotypes, so just because you have a clinical case doesn't mean that you have a vaccine failure. So clinically, I don't think you can really differentiate. But you said it, I think the difference, and you can see this in clinical trials, is that to know if you had a vaccine failure, you have to have immunologic testing. So what it means is that the vaccine, you failed to respond to the vaccine, is my understanding, right? So you did not develop the immunity didn't work, did not occur the way it was supposed to. And so I'll stop there. I mean, there in the sense that going deeper into the immunology, maybe Dr. Perlman could go into that in a way that is easier to explain, but yeah, that's the basic.
The only thing I'd add to that is that vaccine failure, if you don't respond to a vaccine, and assuming one's done all the right testing, antibody testing, and maybe even T-cell testing, is you'd actually just want to know that for the sake of the individual, so that if you have a pathogen that's very common and could cause severe disease in that person you might treat differently. So you might either give them a monoclonal antibody, but there's one that's effective and there is one now, or one might do something else to protect that person. But in terms of the actual discussion we're having, the vaccine failure from a breakthrough, to distinguish it from VAED, is in that discussion, that probably doesn't matter. What matters is to make sure that individual is protected. But that's outside of the discussion we're having.
Okay. There's one related question from the audience saying that, so vaccine failure where exposure to wild virus that leads to a modified or a milder disease, but not enhanced disease, as in modified measles, for example. So this is not a vaccine-associated enhanced disease. So here we are saying if the infection or exposure to the wild virus leads to a modified or milder, not enhanced, nor not higher, not more severe disease. So this is not a vaccine-associated enhanced disease, but could be called also a vaccine-associated enhanced disease.
I think by definition, again, when we say modified, I think we're also saying severe, right? So it's usually a more severe disease, but that's the enhancement, or maybe affecting other organs. Modified in the sense that it might not be your typical presentation, but it also affects other organs. And I think that for the question that you're asking, I would try to make sure that you differentiate vaccine failure, because if somebody has a vaccine failure, they're just not protected, like Dr. Perlman said. So for that person, when it's really relevant to know, you would want to measure antibodies after the vaccination, but it's not even just the antibodies. It also depends on the pathogen, right? So if you could still have protection if you have T-cell mediated immunity. So that the actual failure just means you're not going to be protected from the vaccine. And so this person can have infection and have the usual course, and that's not enhanced disease.
Okay. So the prerequisite for having enhanced disease is having vaccine response. I mean, someone that has vaccine failure cannot do immunologically talking, cannot develop a vaccine-associated enhanced disease, right?
I would say yes. Dr. Perlman?
Yeah, I think that that's generally true, but you don't ever want to say anything definitively in medicine because there's always caveats. So you could imagine having no antibody response, having a great T-cell response or an NK cell response, and making things worse. So, but it's rare. I wouldn't think it would be common. So we just have to be careful to make sure, really use the word really unlikely as opposed to absolutely.
Okay, very good. Thank you for that. Just wanted to ask you, I mean, thinking about limited resource settings, Because in the Brighton collaboration definition, you say, okay, you need to characterize, and it would be good to characterize the immune response and to know what's going on after you use the vaccine when you have a severe case of a disease that it was supposed to be prevented. But in limited resource settings, what could be those tests, lab tests, immunological tests? I mean, I know the general tests, CBCs, I mean, that should be done, but what about the immunological response characterization? So if you are in a limited resource setting, let's say a high-level hospital in one of our countries or one of our regions where you don't have a specific immunological expert labs, but what could be those tests that in those scenarios you can say, okay, that this could give you some ideas that there is something going on, or if you have more data from a big group of people, you might start seeing some patterns that can be interesting to know.
Yeah, I don't know that I can give you, again, we have emphasized, oops, can you still hear me? We have emphasized that there's not a test, right, that can give you the diagnosis. That is a conglomerate of clinical, laboratory, histopathological findings, and so on. And so I think that the key is, again, documenting the vaccination, documenting the actual infection, and then looking at the clinical presentation. The levels of certainty, the lower level of certainty, as you can see, does not include any additional tests. Because if you have those things and also the epidemiologic pattern, you could make a case of vaccine-associated enhanced disease. But the epi there becomes even more important, right? And so I think that if you have diagnostic capability as a minimum, and the other pieces in low resource settings, you could, at least consider a level 3 of certainty. But I think that also depending on the pathogen, part of the investigation to increase that level of certainty and to really start looking into the cases would require some specialized testing. And this is where maybe, identifying specific resources and being able to collaborate with research laboratories or laboratories that are doing this kind of work would be important, but it could be quite pathogen specific. And you saw that in the definition, there are different options listed as not just one single test. But I don't know, Dr. Perman, if you have other suggestions.
I would agree with that. I think that I think what would actually happen is that if there was a problem, if there was a vaccine enhanced disease, the low resource area wouldn't necessarily have to do all the testing, because once it's known, if there's a clinical pattern that's become apparent, then the things that they can do well, they can use. So whether it be simple laboratory testing plus the clinical observations, is there increased in hospitalization, those kinds of things can be done. I don't think you'd expect the low resource area or a setting with low resources to go and make the first diagnosis of vaccine enhanced disease for that pathogen. So I think it's a really good question, and but you'd want to have, and if there was a group of people who were identified clinically, then the next thing to do would be to refer them to the centers as was just discussed, so that they can be, if it's indicated. With measles, every person who had vaccine enhanced disease or RSV, we didn't do all this testing. We knew that this was occurring. So when this pattern occurred, we stopped as soon as we knew that it was an RSV or measles.
And there's the next question. Challenging, because now, as you know, we are using, or some countries are using RSV vaccine in pregnant women. So do you think it's possible that there is a risk of seeing vaccine-associated enhanced disease in this population, how the observation can be changed, and also in the fetus or the newborn that has been transferred some antibodies and to protect him from the from the virus, do you think is a possibility? Have you discussed that? There is a theoretical possibility that that might be occurring?
Yes, a
What
lot of
kind of-
discussions. And you can be assured or reassured that even though, as Dr. Pillman says, maybe you can't say 100% definitively, but the likelihood is minimal because we have a lot of evidence. So, for example, for the mother herself, I would say that all of us, by the time we start becoming pregnant, have already been infected with RSV. So the rate of infection of RSV is very high in the population. And so the vaccine in the mother herself is a booster, and so it's unlikely that women are completely seronegative and that the vaccine response is going to be abnormal, so that they themselves can become infected and have enhanced disease. On the baby side, the baby is not getting the vaccine. The baby is getting the antibodies that the mother produced, because the nice thing about maternal immunization is that it's really antibody dependent, right? So the babies are just counting on the antibody that the mother produced for their own protection. And we have a proof of concept that this does not result in enhanced disease, because we've been using palivizumab for 25 years, giving antibodies passively to the babies, and that has not been observed. And the fact that, again, most women have been immune, and so they already are passing antibodies to their babies, and if they get RSV when they're pregnant, they also have more antibody that goes to the babies, and we don't see that happening. So it's also, protection for a short period of time, and also very nice studies from the 70s and 80s and that show that having those antibodies from day one, when RSV was first identified and described, babies in the first few months of life were already known to have neutralizing antibodies coming from mom, and also after being exposed. And the more antibody you have, you actually have the opposite. You have lesser severity of illness and later onset of illness. So babies are older and they don't get as sick when they get RSV if they have maternal antibody. So this is something that also is always, with RSV, it's always thought of, it's always considered. And for every clinical study that has been done with RSV vaccines, either in pregnant women or in children, it has been assessed and it has not been an issue.
Yeah, and
Okay.
I would add to that is all vaccines are not equal. So both the killed RSV and killed measles vaccine induce very specific kinds of immunological responses that were not useful. That's not going to happen with most vaccines or the natural infection. So it's really, one can't say that because they're vaccinated, one should always think about it, but it's very less likely because it's a different vaccine. It's completely going to do different things.
Thank you for that point. I do like to mention to people who have these concerns that the vaccines today, the technology and the regulatory requirements to get these vaccines out there are much more different and stricter, and therefore vaccines are safer now than what they used to be. And it's very specific to a vaccine. It could be specific to an adjuvant. It could be specific to a pathogen, but it's not happening with the current vaccines for RSV.
Okay, thank you very much. And I have a couple of last questions from the audience. Given the complexity of this topic, what kind of research do you think should be developed in countries of the America? And what could be your recommendations for surveillance, for passive and active surveillance? We know it's rare. It's a very rare, might be a rare and very rare event, but still we need to monitor it and to make sure that everything is okay with vaccines all the time and provide that evidence to population. But what would be the kind of research that you would recommend from the epidemiological and basic sciences too?
Okay, I'll do the epi. So and thank you for sharing the questions ahead of time, because this is why I also added the last slide with the GVD and the Global Vaccine Data Network Protocol, because it is an example of one way to develop a protocol to specifically look for vaccine-associated enhanced disease for a specific vaccine, in this case, COVID, but it could be done in the same way for other vaccines if people are concerned, like dengue and so on, right? So they have established safety surveillance systems that are going to be able to document some of the key pieces like the vaccination, the infection, and assess severity of illness. And you saw how in that protocol, very specific for COVID, they had clinical parameters, so not necessarily immunologic or inflammatory laboratory testing, but standardized severity of illness scores or ways to assess in a way that is consistent. That is something that could be established in any setting, I think, and that's actually the purpose of the GBDN, to do it in different resource settings. So if I were to vote for one type of research, is again safety surveillance, especially post authorization. So when you have already large groups of people who are, if this were to happen, it would be a rare event. So the
Thank you.
You do the laboratory testing after you have that information. So that wouldn't be the first thing you do. And what would be done would be the kinds of things that both of us have mentioned, whether it be looking at antibody titers, cytokines, T-cell responses, macrophage infection, lots of things that would only, to my mind, be indicated once you had a reason to go to the next step and start looking. Failures for the reasons we talked about as well. So that would be the only reason to possibly do some of these things.
Okay, thank you very much. Just one last question from your side. Which sources would you recommend to be informed about this issue? So apart from the Brighton Collaboration website, which other sources you can recommend to our audience to be informed more about the international discussions on this matter that you know already, since you are working constantly in this field?
Again, I think it's pathogen specific. So I'm sure that if you go into dengue, you'll find a number of documents and resources. Dengue is actually a good example because there is severity of illness scores that are available. I think that again, based on the specific pathogen and disease, and also in the vaccines, I would just say you could go in the general literature and try to look for that. I mentioned the GBDN because it's specifically looking for that. I don't think I've seen other protocols that have focused on vaccine-associated enhanced disease right now. But I would also recommend, you have WHO and you have other groups like CDC and other Gates Foundation funded groups that are looking at vaccine safety. And again, I think the limitations are that this is very general vaccine safety, not vaccine-associated enhanced disease, but that there's at least a lot of literature out there and a lot more platforms available to assess safety, which is probably the way to go. I don't know about other more specific sites, to be honest with you.
Mm-hmm. And from the immunology research, is there any group, teams, or institutions that we can refer to, or not?
Specific group, but what would be true is that once you have cases where you think that this might be an issue, then one can either go to the regional laboratories that are in Latin America, or contact the CDC in the US, which sometimes there's at least one textbook on vaccines as total, and that would have information about these different kinds of problems that could arise, different kinds of VAED. So that would be, I don't know, I can show you this textbook. I guess I can't, but I can't. Yeah. So So there's this textbook that just appeared called Vaccines. And as you can see how thick it is, it has quite a bit of information in it. So this might be very useful because it goes across all pathogens.
Okay, very good. Thank you very much, Dr. Munoz, and thank you very much, Dr. Perlman. It has been very, very useful, the presentation. So we really appreciate the support that you show all the time. Thank you very much.
Thank you.
Thank you. I will just say it's challenging, but I think that if you have specific questions and you've had the interest and support, developing a protocol to start somewhere is something that can be done. And that looks like it's an important task. It's an important project to
Thank you
consider.
very much.
Yeah. Happy.
No, mil gracias a ustedes, doctores, por su participación.
I thank you, doctors, for your participation. We had almost 300 participants who were deeply interested in your presentation, your answers, your information, and also it was very interesting to hear everything that you just shared with us. I don't know whether Dr. Salas would like to add something, otherwise we give the floor to Dr. Wittenberg.
Thank you, Dr. Munoz, and thank you, Dr. Perlman. It's been really enlightening to listen to you today.
And if you solve this problem, we want to hear about it.
Yo creo que hay tanta gente interesada.
That since there are so many people interested and working together, more than 335 individuals connected now show this. Alvaro Wittenberg, do you have the camera on? No, Alvaro had to leave. He had another meeting, so Dr. Salas.
To say that for sure, this is a very interesting event to follow up, to really try to collaborate on understanding some of the doubts, some of the questions that we don't have yet answered yet. And of course, there is the challenge that some of the upcoming vaccines, or the vaccines that you already mentioned, probably some countries are going to, or even in the case of Brazil, they're going to go, with the introduction of the vaccine in a no investigation, in a no research setting, which of course the level of quality and the determination of these applying the Brighton criteria is going to be more difficult, because if you don't have that previous determination of the status of the infection, that is going to be more difficult. But of course, we have the support from you. I'm sure to continue working and trying to decipher those challenges, those questions, those things that we are going to face. Because for sure, I mean, this is a very excited moment in vaccination, because we have that pipeline of vaccines that are coming. But it demands that we need to be prepared, and it demands that we need to strengthen our surveillance of ESAVI systems. And that I think that's the message. I mean, we need to be prepared. We need to know more. We need to really understand what we are facing, and of course, having the support from experts as you. It is very important to really continue doing it. So thanks for that.
Gracias, Dr. Salas.
I thank you, Dr. Salas. Felipe, would you like to add something to conclude? We need to conclude. No, thank you. Thank you all. I thank the assistants from the countries. We are looking forward to receiving information on any progress made in getting to know this condition, and the Pan American Health Organization is also preparing some technical guidelines on surveillance of this and other events for the countries of the region. Thank you very much. Thank you all. Again, I thank the panel members, our more than 340 participants connected to this webinar. This shows how important, how interesting it is, and also how enriching it has been to have this webinar for all. Thank you and have a nice afternoon in your country.